Hello and welcome to the session on Chemobrain. My name is Julie Dumas. I'm going to be the stage manager today. Let me introduce who we have on our panel. I am a psychologist. I'm a research psychologist. My research focuses on memory and things that are generally bad for memory. So aging is bad for memory. Cancer is bad for memory. Cancer treatment's bad for memory. So is menopause. Basically being older than 20 is bad for memory. So we're all in the same boat at least. Right, there is that. We also have Dr. Patti O'Brien. She is a faculty member at the University of Vermont at Fletcher Allen, physician at Fletcher Allen. Her expertise is in lymphedema. However, today she's going to represent a cancer survivor who's had Chemobrain. She's going to tell you her story. She's a great speaker in many domains, but she's very good at this. I love hearing her talk about this, although it's not a great thing for her, but she is inspiring, and hopefully you'll all agree when she does her thing. We also have her personal speech pathologist, Moira Mulligan, as well as a professional speech pathologist. And she'll talk to, I think they might do a little dog and pony about how they treated Patti's difficulty specifically, and then general treatment possibilities that a speech-language pathologist might be able to do. And we also have Dr. Owen Drudge, who is a neuropsychologist at the Memory Center at Fletcher Allen. He'll talk a little bit about other possibilities for treatment of Chemobrain. I also had a handout that Nancy, our helper with the pink shawl in the back, has with basic sort of contact information, the number of the memory center, the number of speech-language pathology, our email addresses, a couple of links that have a lot of letters and are more annoying when they're on a piece of paper than on a computer. But if you haven't gotten that, you can raise your hand and Nancy can come around to you, or you can find her on your way out the door. There's a hand up here in the third row. Okay, let me get going here. So why talk about Chemobrain? Chemobrain is a term, I think it probably was first generated by cancer survivors who noticed that they weren't as good or as quick at thinking as they maybe were before cancer, before a diagnosis. However, it may mean different things to survivors versus clinicians. The technical term is neurocognitive dysfunction after cancer or cancer treatments or memory disorder. So one thing we want to talk about before we say, yes, you have a cognitive disorder, we want to make sure that there are a number of things that we can treat that do improve cognition. So there are a number of not common, but things that happen fairly frequently after a diagnosis of cancer and cancer treatment. One is stress. It's obviously a stressful time. All the appointments and treatments and activities that have to go on related to cancer and cancer treatment are stressful. And if we can do anything to minimize that stress, we can improve cognitive functioning. Depression actually maybe should be at the top. It's the #1 biggest problem that causes cognitive complaints and cognitive impairment. Even outside of cancer, depression that is not related to cancer causes difficulties and impairments in cognition. So we want to talk to our physicians, talk about depression, talk about getting treatment for depression. I want to skip to lack of sleep in a similar way. Lack of sleep is something that is difficult to treat, but also if we can get more sleep, deal with fatigue, get more rest, we can improve cognitive functioning. There are some research studies that show that lack of sleep is as bad for driving as 2 glasses of wine. So it's not impairing in terms of normal cognitive functioning, whether or not you've had cancer. So lack of sleep is a big thing that if we can fix it, we can improve cognition. Let me skip to the drugs, or let me go back to the drugs. Many types of drugs impair cognition. There are very few that are actually beneficial for cognition. Steroids, excuse me, hormones or anti-hormone treatment, those all have effects in the brain and are potentially have negative effects on cognition. Pain is another thing. If we can decrease pain symptoms, we can perhaps improve cognition. However, even if you get all of these things settled out, you're feeling good, you're not depressed, people still have difficulties with cognitive functioning. And I should have maybe said earlier that not everyone has Chemobrain, but some people do, even when we treat all of these things that are treatable. So what are some examples of cognitive difficulties? One very common one is, I came to the store, what am I here to get? And you come home with milk, but then you get home and you realize you went for the bread. So you didn't come home with the right thing. Another is, I met a woman yesterday and I just cannot remember her name. What was her name? I remember what she looks like, but I can't do the name. Other things are, I was supposed to pick up my daughter today and I totally forgot. And you'll hear Dr. O'Brien talk about that example of a story. And these things are things that happen to anybody, not specific to cancer or cancer treatment. However, they might become more frequent. They might be different from what you're used to experiencing. And one thing to note about it is when other people start to notice. So you might think, I'm not as good as I used to. I was the best rememberer of all time. I never forgot a single face, and now I'm just not as good as I used to be. And if your partner notices that, that's something to be concerned about. Excuse me. So why are we going to talk about Chemobrain? What's the point of this panel? We want to explain sort of the functional changes, general things that occur after chemotherapy. And it's not just chemotherapy. Sometimes it's a cancer diagnosis itself. It might be cancer affecting the brain. Could be radiation affecting the brain. We're doing a research study at the University of Vermont to try to pull apart these two things. We're at the end of it, but we haven't quite analyzed the data yet. And we want you to be able to talk about this and feel comfortable talking to your providers about any difficulties you may be experiencing. We may be missing, in terms of clinical or clinicians, we may be missing people who are having problems if you aren't aware that this is a possibility after cancer and cancer treatment. And we want to know how you perceive the problem. So get back to my example of someone who's this amazing rememberer. They may go to Owen and say, I'm not as good as I used to be, and they may perform perfectly within normal limits on his tests, but you're just not as good as you used to be. And that's, that is important. You're not performing poorly. But this sort of subjective feeling of I'm not as good as I used to be is important. And again, in the research community, we're finding that the subjective reports are as important as objective performance. We don't know what the end result will be, but we're showing that there are differences in brain structure and function in people who have subjective reports of cognitive impairment. So we certainly want to hear from you. We want to send you to Owen and to Moira to get assessed. But even if you perform with flying colors, you still may not be as good as you used to be, and that's important to let your providers know about. Okay, so I'm going to skip this for now, and I'm going to hand it over to Patti, if I can work the computer, which is questionable. Patti, if you want to, I'll work on your slide. I'll work on the mouse. Sorry, where's my computer guy? I feel like I don't have a mouse. Do you have a mouse? It comes back after, there it is. It comes back after a few minutes. It just takes a while. So this is me, so we're going to quit me, sorry. You're down here, and you are there. Go ahead.
Okay.
And you speak.
Yeah.
Perfect, okay.
Okay, so I'm Patti O'Brien, and I've been doing this dog and pony show for years at breast cancer conferences trying to talk about Chemobrain. And the three of us have been doing this together, and I'm very happy that Moira is going to join us this year because Moira was my therapist when I was diagnosed with Chemobrain. So I'm here because I've had Chemobrain, been there, done that. So I had the disease, but my concern really was how do I raise my children when I feel like I'm really cognitively mixed up. And I needed to stop practicing medicine for a while because I really couldn't function at the level that I needed to as a physician. So why talk about it? I feel like we need to talk about it over and over and over again because those of you in the audience may be having difficulty processing what we're saying. So we may say the same thing several times. We may intentionally be being repetitive because I know I needed to hear things multiple times because I had a hard time processing what was coming in. So neurocognitive dysfunction is what your doctor may tell you you have. But most of you are probably going to learn about Chemobrain from other survivors. I did not learn about Chemobrain in medical school. I learned about Chemobrain from another survivor having a cup of tea in my kitchen, and my kitchen was a wreck, and it's still a wreck, but for different reasons. And she was just like, Patti, you seem to be having difficulty processing. And do you think you are having Chemobrain? And at that point in time, Chemobrain wasn't, now every survivor knows about Chemobrain, and it's, we all joke about it. It's like, oh, Chemobrain. But 20 years ago, when I was trying to get information about Chemobrain, There wasn't as much information. It was not necessarily an accepted diagnosis. And it's now out there, but all of us need to share that information and talk to our doctors about it and really be very open about what our needs are. So I had really significant chemobrain. I doubt any of you will ever get as significant chemobrain as I had. I hope you won't, because the treatments for cancer now are very different than the treatments 20 years ago. The good news is that treatments for cancer have come a long way, and a lot of the drugs that I was exposed to, you will not be exposed to. So I had a very advanced, locally advanced tumor, and so I did the standard chemotherapy at standard doses. But then after that, because I had young children and I really wanted experimental care on top of that, I then went for high-dose chemotherapy with a bone marrow transplant, which they don't do for breast cancer anymore. They get much better cures with newer drugs. So I got a lot of drugs that they don't do anymore, okay? Along with the chemotherapy, I got a lot of steroids. I went through menopause. Because I had a bone marrow transplant, I had very low blood counts and got a lot of infections. I was in the hospital for about a month with a lot of infections. And then I got a very experimental drug, which again, we don't use anymore. And I took daily injections of interleukin-2 for 21 days as part of, again, experimental therapy. The good news is there's lots of much, much better ways to get cures now. We didn't have Herceptin then. Taxol was still coming from trees, literally, trees, you know? So we've come a very long way, and I hope none of you will have the severity of chemobrain. But if you do, I want you to know that there's lots of resources for you, and you should leave here knowing what those resources are. I also was depressed, and so every time I told people that I'm having difficulty processing, they would say to me, "You're depressed, go see psychiatry." And I was depressed, but that wasn't all that I was. So I admit that I did have a depression, and I did have that treated, and I did get a lot of psychotherapy, and I was very, very tired. I had very poor blood counts after my bone marrow transplant. And I had two little kids that were running wild, and, you know, my house was really a mess then. I had a small stroke, so part of my cerebellum was damaged, and I had a lot of blood transfusions, platelet transfusions, blood reactions. So my body really felt like it had just been shaken, like somebody took my brain and shook it. And I spent a lot of time in scanners with them trying to figure out why my brain didn't work. I really don't want to frighten anybody to think, you know, oh my God, that's going to happen to me, because it shouldn't happen to you, because we've come a long way. But I really needed significant help and intervention. I would do things like forget to pick my kids up. So I love Dr. Muss. He was my oncologist, and I would tell Dr. Muss, I'm having this memory problem, and he goes, "Oh, Patti, I lose my keys all the time too." And I'm like, I'm not losing my keys, I'm losing my kids. That's like a different order of magnitude. So my husband got my kids cell phones, got me a cell phone because I would get lost driving home. You know, we tried to adapt. Somebody should have taken my driver's license away from me. I was that cognitively impaired. They didn't. But I I had such poor hand-eye coordination. It used to be you would park your car right next to Fletcher Allen if you were going in for radiation, so they had a special little parking lot for radiation patients. And I was driving into radiation, and a doctor in the parking lot waved, and I went to wave, and I couldn't coordinate waving and putting on the brake. I literally drove my car into Fletcher Allen. So my bumper hit the building of Fletcher Allen. And nobody took my driver's license away. Nobody said, should you drive home from radiation therapy? That corner where you leave Fletcher Allen and, go towards the jug handle, I cannot tell you how many times I hit the curb, went over the curb. Nobody took my driver's license away from me. We got we got an automatic because I could no longer drive the standard. But we just switched the cars. We got me a new car with a better bumper. But I kept driving. So I talk about this very publicly because I thank God that I didn't kill anybody with my bad driving. People should have intervened. People should have said, Dr. O'Brien, you're out to lunch, and you should not be driving a car. And nobody did that to me. So I really was in this maze with a big black cloud over me and needed some help. And fortunately, I kept harassing my doctor, Dr. Musk, and he said, I don't know what to do for you. And so I harassed him into a neurology consult, and my neurologist was like, I don't know what this Chemobrain stuff is. And I would bring him articles, and I was doing the literature research. And finally, he hooked me up with Moira. And Moira will tell you what she did with me. But this is the slide that really helped me understand my brain. So let me just walk you through this. This is two twins. This is the sister with breast cancer, and this is her twin sister who did not have breast cancer and did not have Chemobrain. And I'm going to super try to simplify what this says. But what they're asking them to do in each of these scans is to do more and more difficult math problems. So here's the sister who's had breast cancer who does a simple math problem. Look, and how much of your brain is working is how much it lights up. So sister with breast cancer had chemotherapy, simple math problem. It takes a lot of her brain to do it. She can do the math problem, but it takes a lot of her brain to do it. Her sister, no problem. A little bit more complicated a math problem. Chemobrain sister, more of her brain is working harder, more connections are trying to pull in. They both answer the math problems. They're both getting the correct answers, but the one with chemo damage is working harder. More of her brain is working. Give them a really tough problem again. The woman with the Chemobrain's answering the problems, but think of how, if that was your muscle, and instead of using a few muscles, you're using all of your muscles. You're going to be really tired by the end of the day. And that's what really helped me see why I was so tired by the end of the day. And by the end of the day, my kids could talk me into anything. Yeah, whatever you want, I mean, and my kids knew it. They knew that I could wake up in the morning and be full of energy, but by the end of the day, they could totally manipulate their mother. And so there really was a difference in how my brain worked. But the good news is that our brains has a lot of plasticity, and we can also heal. So I'm going to now turn it over to Moira, who was a therapist.
It's going to take me a second to switch the slides, but if you want to go ahead.
speech and language pathologist, and I work at Fletcher Allen Healthcare. And you can go to the
Next one. Okay.
So I do think, as Patti said, and it's really important to understand, is that we've come a long ways. And so this before and now, before is Patti, 20 years ago when we met, and where the state was as far as this information. So really no data existed to substantiate the patient reports. So patients were saying, geez, I'm having problems. But there weren't any research studies. There was no really, even a lot of combined clinical data to confirm that that was something other than what everyone kept saying is, well, you're tired and you have a lot going on. So you're depressed and you're tired, and so that's the issue. These factors, the lack of recognition and the lack of data, really made it difficult for people who experienced this. There was no validation of what was happening. So they're coming in and saying, this is what I'm experiencing, and it was being dismissed. So that adds to, of course, the stress and a sense of isolation, too, of just, I'm struggling, and everyone keeps telling me that, oh no, you're just tired. So with that, intervention wasn't really available because for those exact same reasons. If it's depression, then you would treat the depression, and a speech-language pathologist or an occupational therapist wouldn't be the resource. If it's really due to fatigue, if it's truly fatigue, then getting sleep is the best idea, rather than trying to do some other problem-solving or intervention. When I met Patti, she came in, and frankly, I was in the same position she was around, I'm not sure what to do, because I didn't have a history with quote-unquote Chemobrain. And so even looking through our literature, this work we had was really around brain injury, which is very different. And a lot of things have evolved since that time in both those areas, the recognition of the impact of chemo, but also the recognition of brain injury and some of the things you can do and the neuroplasticity in the brain. So now research confirms the possibility that someone has cognitively related issues from the treatment, in addition to the other reasons they might have cognitive changes. Patient experience is validated, so if you're talking to your physician, they're going to recognize that, yes, this is a legitimate thing, which you would hope just by the fact that you're saying it means it's a legitimate thing. But now there is data, so you've at least got that backup. And some of the research does show that the cognitive changes don't worsen over time strictly from the treatment. As Julie said, all of our cognition is changing over time, and unfortunately it's not this curve post-40, but it's that curve post-40, or at least even at the very best. So you do have the factor that we have changing bodies and brains, and so that is compounded by whatever may be happening with your treatment. The other is there are compensatory strategies, and really the speech-language pathologist, the occupational therapist, or even your own problem solving around this is all about compensatory strategies at this point. As Patti said, the interventions have decreased or become more refined, and so people are not going to see the kinds of things that Patti experienced, or are much less likely to, but you're likely to have some impact. Next. So some of the strategies, some really common ones, this is not high tech, use of lists, paper and or electronic technology, use of planners and apps. So one of the things, I look at these and I still laugh because, so someone says, well, write things down. These are great strategies if you're someone who already knows how to do it. If you're a list maker and you've always been a list maker, that's going to work for you. If you've never used lists and it's sort of counterintuitive for you, and suddenly you have these challenges, it doesn't come to you like that of, oh, I'll make a list and this is how I should arrange it and this is how I should keep it. that's when those strategies, you might be able to get help from people who spend a lot of time figuring out what are some easy ways to use strategies that will help or not help. And they can help you work through preferences. If you're not someone who uses an app, well then probably starting right now is not the time to do it. My husband used Post-its. You know, they work for him, they've always worked for him. If I use Post-it, they end up stuck to my sleeve, they're on the grocery bag, they're on the floor of my car, and I don't know what's on any of them. Post-its is not the answer for me. So going to see a professional who might be able to say, well, you know, writing down lists really isn't for you, or you say, I hate to write down lists, I end up losing them, the list gets longer and longer and I don't know what I'm doing. Someone can help you decide, well, what strategy will work without adding more stress, what is more intuitive for me and would address the specific issues. The other is, there may be some things you can tolerate that aren't quite what they used to be, and other things that you want to prioritize for change. So again, not everyone really needs to go see someone to solve these problems. There are kinds of things that you can try and self-diagnose, but if that's hard and it's not working, there are resources to tap into. When Patti came in, one of the prime things was she was motivated as heck. I mean, she knew it was there, she wanted to do something about it, and frustrated. You know, I keep being told it's depression. You know, that's not, it's more than that, it's more than that. And that is a real key factor. Someone's insight and motivation to do something different is key. If you're just not ready, that's okay. The strategies and change is not for everybody at the same point in time. So Patti was all there. She had all her own ideas, you know, well, I've tried this, and was really clear on the things she thought would or wouldn't work. But it was also game for, okay, well, I'll try that, and coming back 2 weeks later and saying, forget it, you know, that's not working. So keeping that in mind, each individual is really key to the kinds of approaches that might work. So some other things, minimize distractions and multitasking. Research now shows us anyways that multitasking isn't really good for anybody. Nobody does that very well. So the idea about 10 years ago, everyone was all about multitasking. Well, the research shows that everyone does everything a little less well when you multitask. So if you think of those brain scan slides, if that's the energy it takes to do one thing, imagine the energy, what your brain is doing if you're trying to do 2 or 3 things and you're switching before. It's so much for your brain to do. So to really think for yourself about, okay, you know, what is my priority, and be able to focus on a task one at a time. Decreasing medications that impact cognition if possible. One of the things about treating depression, or really almost anything, is drugs work oftentimes on the brain. And so they may cure or help one area, but they have an impact on another. So a lot of drugs have neural impact, and whether it's making someone a little groggy or little just processing, foggy is a word I hear a lot, you know, I feel a little foggy. So if you can, but again, you're balancing things. You're balancing, you know, life-saving and extending medication, depression medication, and all those things, your doctor and you need to work together to figure out what the priority is. And then exercise, relaxation, and stress management. I'm excited about some of the work being done now with oncology rehab, and we're seeing it with not so new cardiac rehab, but that the impact of stress management and exercise is really huge on being able to maintain just a more steady state, and again, addressing depression, being a little more upbeat. And then sleep. Sleep is a valuable thing for all of us. So the last is trust your instincts. I mean, really, if you're experiencing it, then it's real. And the key is, who do you seek for help, or do you? Do you acknowledge that this is existing for you, but your focus is different? So where does it fit in your decision to approach it or change it, given your other priorities? If indeed you think, I really want help with this, request referral to a speech-language pathologist or an occupational therapist with a real focus of, I just want help to compensate for this. And remember, it really is compensatory. They're going to help you do workarounds. Neuropsych testing, which Owen will talk more about, it may be helpful for validation or disability determination. Again, I think our direction in what can we do to treat it is still focused on compensatory strategies and weighing out for all of these, what is your priority in your day-to-day life as you balance everything else. But I think the biggest is trust your instincts and take care of yourself in a sort of whole body way is really the key.
I can't sit and talk.
No.
But I've talked about in previous years when I did this was more about neuropsychological testing, what the components were and what the specific deficits were that we looked at. More recently, last May, at the Leukemia and Lymphoma Society meeting at Stowe, I had a 90-minute talk on Chemobrain, so I had a chance to, really spread it out some. And I was, in preparing for this, I sort of recalling what parts were people more awake for, that they, and which ones did people seem to have more questions about afterwards. And knowing what other people were going to talk about here, I decided to pull out something that's a little different, talking more about some of the other interventions, starting with medicinal type interventions, pharmacological and alternative, and then some non-medicinal or non-pharmacological interventions. And if people have other questions about neuropsych testing, you can catch that in the question and answer piece. What do I push? This guy?
Yep, I should work with this, just this. That would be the easiest
Oh, that's
thing.
easier, yeah.
Yeah.
Okay. Neurostimulants, there's been a big interest in this, and a lot of these treatments have what's called face validity, which is really not any kind of real scientific validity. Face validity is, it seems like it should work, so let's use it. And because pretty much anybody who has any sort of brain disorder, and certainly anybody who has gone through like cancer treatments of radiation and or chemotherapy struggle with fatigue for a number of reasons, whether it's the full systemic changes that the body's going through or the brain changes that we saw in the PET scans, where it just requires so much more mental activity to get from point A to point B, or the sleep disturbance. So given that fatigue is a big part of it, you'd want to take a look at, okay, what do we have for medications that might help with fatigue? The two that are commonly used with like traumatic brain injury and stroke are methylphenidate, which is the patent name, most common name is Ritalin, although it comes in other forms, and modafinil, which is Provigil. Methylphenidate is used primarily for attention deficit disorder. Modafinil is used primarily for narcolepsy, although I think probably less than 1% of the prescriptions, for modafinil are used for narcolepsy. The thought is, one, you can take care of some of the fatigue, you can increase mental activity, and all of that should help with the Chemobrain problems. What we found is methylphenidate is used a lot, but the research really hasn't held up on that. It's even to the point where it's not really supported all that well for, counteracting fatigue. It doesn't show any beneficial effect for cognition. Modafinil or Provigil does seem to have a bit more support in that there are some positive findings. It shows that it can increase attention, can decrease fatigue, and also help with mood. So that's one that they're continuing to work with. The next one is cholinesterase inhibitors. This comes from a completely different branch. This is the first go-to drug for dementia like Alzheimer's. The trade name is Aricept. The thought is, okay, well, we're having Chemobrain. One of the hallmark features of it is memory problems. Let's try a medication that helps with memory. That seems like that makes sense, but really, donepezil is only supposed to work with a very specific type of brain neuropathology, and not used for traumatic brain injury or stroke, although I do see people using it for all those things at times. And it's not supposed to reverse the effects. It's, with Alzheimer's, you want to be taking it early on, and it's supposed to slow the decline. But lo and behold, there is some promise for it being neuroprotective with chemotherapy-induced changes, although once again, this is, there'll be a few of these that are on this level that it's shown the most promise with rodents, which say, okay, well, I'm not gonna go to my doc and say I have to have this because I heard that it's good for mice who are undergoing chemotherapy. But we do share a good bit of genetic material with them, so that's one that does seem to have some promise. The next one is the SSRIs, which is an antidepressant. Fluoxetine was the first one, most commonly known as Prozac, but there's also a lot of sister drugs like paroxetine or Paxil, Zoloft or sertraline, Celexa, citalopram. Sort of all very quite similar. Most of the research has been done with Prozac or fluoxetine because it's been around the longest. There's a couple reasons why this would be a good drug to go to. Just one, because of the high incidence of depression that goes along with recovery from cancer and Chemobrain. So you can get the help from that. But they mentioned before that when you have depression, you also have memory difficulties. Some of it has to do with the secondary effects, the sleep, the distraction, the worry, but also there does seem to be some brain changes that go along with depression. And those do tend to get reversed sometimes when you're successfully treated with an antidepressant, like fluoxetine. But separate from that, not depressed, but are having chemotherapy-related cognitive impairments. If you take fluoxetine, that does seem to reverse the effects of that. Once again, it does seem to have restorative effects in rats, and it has neuroprotective effects in humans. So that does seem to have some validity also. They have found that when you take it after you've had memory problems, sometimes it will increase the size of the hippocampus, which is one of the brain structures that have to do with memory. Next one that they thought had some hope is a EPO. It's a anemia-related drug, which I thought was neuroprotective, particularly in cases where people were, having some low blood counts and anemia and all of that, and they found some spillover effect that they thought maybe this does help with increased brain function. But it seems like it only works if anemia is an issue, that there isn't any separate effect, any neuroprotective or neuroregenerative effect. Vitamin E, that was one that was extremely hot for a while for treating or preventing Alzheimer's disease or age-related cognitive declines, and people were taking pretty heroic doses of it. I can't remember what it was, something like maybe 20 times sort of the recommended daily dosage. And that's not clear. The idea was that it would stop the oxidative stress downward cascade that goes along with chemotherapy. The results are really inconclusive. The only study I found where it seems like it might help is when it's combined with donepezil, that the two of them do a little more. Last one is ginkgo biloba, which was another one that was extremely hot as far as alternative medicines go for treating memory deficits. They've finally gotten around and done some really good studies with this, large samples, double-blind, multiple arms of those who get chemo, those who don't, those who get the ginkgo and those who don't. And they really found that there really didn't seem to be any benefit from taking it specifically with regards to chemotherapy changes. Any questions about that stuff at all before I move on to the next one? The one that I find that I've always gotten excited about is treatment of cognitive deficits from physical activity. We have seen in the news and all that some of the cognitive retraining programs that you can get that you're supposed to help improve your memory and your mental function by doing cognitive activities. The research to start with really is more supportive for physical activity being beneficial, both whether as a neuroprotective mechanism. Those who are more fit physically, do tend to have less decline over time. And those who, are out of shape and get with a physical program benefit from it, and also have secondary cognitive benefits. I can't remember which. Yeah, that there's no cutoff for it. That even if you've been reasonably sedentary for a good chunk of your life, if you pick it up, you still get benefit in later life. That it's also been associated with not only improved cognition, but lower risk of dementia later on. Those who do it proactively, they have less mental decline. And it does seem to help the ones who are in the worst physical shape to start with, and possibly women more than men. So the ones who start out in great shape, if they bump that up, they don't get as much benefit as those who are already who are starting out behind a bit. Not a lot of literature specific to chemotherapy changes, but I really do think it probably does generalize to it. One of the questions that was looked at, okay, well, if somebody is recovering from chemotherapy or in the middle of it, should they be doing any sort of aggressive exercise program? And this study, which is fairly recent, looked at it and said, yeah, that certainly aerobic and or combined exercise program can be safely tolerated by people who are going through the treatments. And there is some indication that there may be more cognitive benefit from a mixed aerobic and weight training program, alternating days or something of the sort. With regards to exercise and chemotherapy recovery, a number of studies have found that it's good for increasing self-esteem, decreases depression, increases scores on quality of life indicators, also helps people stick with chemo. The dropout rate from chemo is lower. And of course it does, hopefully improve fitness too. As far as actual cognitive benefits, I found this study, and I was really kind of excited when you go through and start reading the abstract. You find, okay, in the title of it was very clear that, exercise decreases cognitive impairments following chemotherapy. And I was thinking, okay, that's fine. I'm reading through, what were the condition, all that. And then I got to the part where I sort of skipped over the subjects, and I got to the method, and that, the participants spent, a number of hours on the exercise wheel at night. I thought, okay, geez, yeah, they missed something, and indeed it was rats. But once again, I think there is some carryover that they should be. If the rats can get chemotherapy, and it does help, their memory and problem solving, there probably is good for humans too. I'm going to cut it off here.
That's what I was going to say.
Yep.
We have 5 minutes left in the
Yep.
session, and we all like to talk about this. So we're going to give you guys the opportunity to ask any questions, and then we'll be available. I think we probably have to leave the room for the next session after us, but we'll be available outside if we don't get it covered in the next 5 minutes. We're going to go stage manage as I'm supposed to do. I saw some hands, and I saw the one in the far back against the wall first.
Are there any studies being done on Chemobrain for years after your chemotherapy has?
Yeah, I just read something the other day, an article. So the question was, there are any studies about years after chemotherapy and survivors, a number of years out? There's some work by some of my friends and colleagues at the University of Iowa looking at, they're interested in geriatric psychiatry and older adults, and they show survivors 10 years, at least minimum of 10 years out from the cancer diagnosis and treatment, that there are some decreased cognitive performance compared to a control group of age match, education match. And however, I've also seen recently that I think a study has followed people from the time of cancer diagnosis and treatment, and then followed them out 10 years later, and they don't have much change. So there's this interesting difference between people with cancer and people without cancer. So they're kind of at a lower level to begin with, and they kind of maintain that lower level over time. Another thing that we've shown as well is that there's cognitive changes and decreased performance about a month after chemotherapy, and it mostly recovers a year later. However, what doesn't recover is the subjective report. So I still feel like I'm as bad as I was in the midst of all the bad stuff, but you're actually performing as well as you were at the beginning. So anyway, that's just some information. So another hand in the back, but I don't see it now. Next. Yes, the green scarf.
So, I have a friend who's had chemo, complained a lot about Chemobrain, and she's 4 years out from chemo and really having some dementia-like symptoms. Is there a way to differentiate between Chemobrain, residual Chemobrain, and rather, or dementia issues going on?
I'm going to hand that to Owen. Do you have a... I can make it up, but I don't. You're more qualified.
Yeah. I'll be making it up too.
Okay.
Just because kind of probably the truthful answer is no on testing. They won't show up just because, even though we use one term, Chemobrain, it really is vastly heterogeneous. You have all different types of brains going into it. Everybody's different, with regards to how our brains work, the level we're functioning at it. Our genetic makeup will make a difference, the type of chemotherapy we got, and what our life experiences were like after it. And being individuals, one thing that else is different is how our brains age over time. So I could make a case for if somebody was sort of in that fast track for cognitive decline, that the chemotherapy treatments might have jump-started it a little bit. And there's no reason why, God forbid, it happens, that you can have two things. One, you can have cancer and get chemotherapy treatments, and the other is that you could get, some sort of progressive dementia. Probably, taking a look at somebody once, I'd be guessing, and I would just sort of say, well, the deficits on testing and what I'm hearing are really out of line from what I have seen with people having chemotherapy-related changes. I would get much smarter seeing them again a year or two later, where it'd have 2 points. And if it's, you know, if we think they start here, they're here, and 2 years later they're here, then I'd be pretty comfortable making the call that it, you know, that it was something else on top of it. So the answer was, I don't know.
Very helpful.
Okay.
Yes.
Okay, so the second part about children that receive chemo and their academic abilities.
I raised 2 kids. Other than that, I don't have anything to do with them professionally. So I would really be making it up to talk about kids being treated.
Maybe more
Yeah.
could talk about developmental.
No. Are there crucial stages of development where it's more? I assume there are, just because there's crucial, crucial both for the neuroplasticity as far as, you're relearning things versus learning for the first time, those kinds of issues. But as far as how neurologic development and then academic or school performance, I really have no experience related to cancer treatment.
Me neither. I will say that children's brains are more plastic than our adult brains, so they have that benefit. I think there's a ton of research, again, that I don't know anything about since I studied menopause, so we're all the older groups here. But I think there's a lot of known information. We are just not the people who know it.
Yeah.
All right, I guess we should leave here, and we'll be available outside. Thank you.